All right, so if you are happy and ready, let's get 5 minutes on the clock for reading time. Your time starts now. Case 1. Candidate Information. Instructions. Review the following patient record summary, clinical examination findings, and investigation results. Your examiner will ask you a series of questions based on this information. You have 15 minutes to complete this case. The time for each question will be managed by the examiner. Patient record summary. Name: Dennis Armstrong. Age: 28 years. Gender: male. Indigenous status: not Aboriginal or Torres Strait Islander. Allergies and adverse reactions: nil. Medications: nil. Past history: nil significant. Social history: occupation: graphic designer. Non-smoker, occasional alcohol use. Single with no children. Family history: mother with hypothyroidism. Father with type 2 diabetes. Vaccination and preventative activities: up to date with all routine vaccinations with regular health checkups. Scenario: Dennis Armstrong, aged 28 years, presents to your clinic with complaints of fatigue, weight gain, and feeling cold all the time over the last few months. He also mentions having dry skin and hair loss. Dennis is concerned that these symptoms are affecting his daily life and work performance. He seeks advice on possible causes and management strategies to improve his symptoms. Clinical examination findings. General appearance: slightly overweight, appearing tired. Vital signs: blood pressure of 110 on 70, heart rate of 60, temperature of 36.2, respiratory rate of 14, SATs of 99% on room air. Cardiovascular examination. Heart sounds are normal S1 and S2 with no murmurs. Peripheral pulses are normal and there is no peripheral edema. Respiratory examination. Clear breath sounds oscillated bilaterally. Abdominal examination is soft, non-tender with no organomegaly. Skin examination shows dry skin with thinning hair. Investigations. Full blood count. Hemoglobin 125, normal. White blood cell count 6, normal. Platelets 240, normal. Lipid profile: total cholesterol of 5.5, high end of normal. LDL 3.2, mildly elevated. HDL 1, normal. Triglycerides 1.8, normal. Sodium 138, normal. Potassium 4.1, normal. Calcium 2.3, normal. Renal function: eGFR 95, normal. Creatinine 65, normal. Iron studies: serum ferritin 20, borderline low. Serum iron 11, low. Transferrin saturation 16%, low. Thyroid function tests: TSH 9, elevated. Free T4 8, low. Okay, your reading time is up. Your 15 minutes of case time starts now. So, what do you think the possible differential diagnoses are for Dennis's symptoms?
Yeah, sure. So differentials, I think the one that stands out the most is overt hypothyroidism. And I say overt because the T4 level is low. This could be secondary due to a number of causes, something like decurvent thyroiditis, could be painless thyroiditis as well. Um, so yeah, those are two causes for it. I think other differentials less likely, but important to bear in mind. Things like Cushing's disease is important to consider. And then I think for the fatigue in general, looking at considering things like liver disease, chronic liver disease, chronic kidney disease. He's very young, so it's extremely unlikely, but heart failure, bear in the back of your mind. Sleep apnea is important to consider. Anemia is a possibility as well, given the fatigue. Um, I think other causes like diabetes, celiac disease, less likely, but important to keep in the back of your mind. And I think mental health conditions, so depression, anxiety, again, less likely, but important to consider. Um, and I think,
What
yeah,
kind
I think
of
that's
red flags would you be looking for in this case?
red flags. I guess red flags specific for his current symptoms or for
Hmm.
both. Yeah, okay. Yeah, so I guess fevers. He's had weight gain. So I guess fevers, night sweats, lymphadenopathy you can consider as well. I think a thyroid cancer is probably unlikely with a hypothyroidism. So it's very unlikely unless it's like a cold type nodule. So I think that's probably unlikely. But yeah, I think just considering those aspects, I think other red flags, just his alcohol, how much is he drinking? That's important to consider. His family history is a bit of a red flag. His mother's got hypothyroidism as well. So that's important to note. And we do note his low iron levels as well. So just in a young person, why is the iron level low? Has he got any anemia? It's important to consider things like gut cancers. Is there any bleeding from anywhere? Rectal bleeding. So it's just important to bear that in mind as well. Um,
Yep. And are there
yeah.
any other investigations you would consider as next line?
Yep, definitely. So I think I'll repeat the TSH again and the T4 and T3 as well. So I do that immediately. I would also add on the antibodies like anti-thyroid peroxidase antibodies, specifically for Hashimoto's disease, and also the thyroglobulin antibodies as well. And I think that's what I would consider. I don't think TSI and TRAbs are indicated, but I think it's probably not indicated. I think mainly the TPO and thyroglobulin is what I would start with. TSH, T3, T4. I can't just on his general examination. Yeah, there's no mention about the thyroid, but I'd probably definitely have a feel of the thyroid, make sure there's no massive nodules or anything unusual that I can feel there that would require an ultrasound. I suspect not, but that's something I would keep at the back of my mind as well.
Yep.
Other blood tests, yep.
And if we say the anti-TPO levels came back positive, um, based on existing guidelines, what would be your management strategy for his hypothyroidism?
Yep. So if it came back positive, so Hashimoto's is likely possible. So I guess starting with educating the patient, giving a leaflet, maybe from, say, the Better Health channel regarding Hashimoto's disease, explaining to him that it involves a gland in his neck that's just not functioning or producing the hormone called thyroxine, which is responsible for things like metabolism and keeping, the underfunctioning of that hormone is what's leading to his symptoms that he's experiencing. So just explaining that in a sort of patient-friendly language. And then I guess, jumping straight to pharmacological management. Levothyroxine, I think specifically given he's got overt hypothyroidism and he's symptomatic, I would start him on 1.6 micrograms per kilo. I'm not sure what his weight was here, but yeah, I guess based on the weight there, I would calculate that. Yeah, I think I would start him and review probably. Just advise him again with the levothyroxine needs to be taken on an empty stomach, can't be taken with any kind of food and can't take any supplements like iron, calcium, anything like that. And yeah, it needs to be stored very specifically and can't take it with any other medications. And yeah, I think I would organize probably a referral. I mean, maybe not necessarily right now, but considering sort of endocrinology input down the track, if there was any major issues, certainly you'd want to review him. I reckon after you start him on the levothyroxine, probably just see him again in about a couple of days, see how he's going. But normally it's about every 4 to 6 weeks that you would titrate. So you wait for 46 weeks, repeat the TSH, see what's happening with the level there. And based on that, I think you could titrate, increase as necessary, but at least wait about 4 to 6 weeks before increasing. Other management strategies, I guess, non-pharmacological means, if he's slightly overweight, so just talking about importance of good diet, exercise, Mediterranean type diets, regular exercise to try and keep the weight off. But even trying to lose some weight, 30 to 60 minutes, moderate intensity per day. It doesn't say he's a smoker here, and occasional alcohol, just clarifying that, advising him, the safe limits, like no more than 10 in a week. And yeah, I guess just addressing his other symptoms, the hair loss as well, just discussing that, how that's impacting his life. Does he need sort of assistance with that? Maybe referral to sort of a hair loss, like a dermatologist to discuss that further. How's that going? Reviewing that, and he's low iron as well. I note here, so probably starting on some oral iron supplements. Something like Ferrograd would be fine. Again, making sure he doesn't take that at the same time as the thyroxine.
Perfect.
And
Just on that note, how would you explain the results of the iron studies to him?
Yeah, so I would tell him that his iron levels are low. So I would tell him that we look at something called the ferritin, which is kind of like the money in the bank, is probably the analogy I'd use. So that is borderline low. The cutoff is generally 30 is the minimum sort of. So it's towards 20, I would say. So I would just tell him that this does need to be replaced, but more importantly, we need to consider why he's low. I mean, is it because of dietary causes? Is he bleeding from somewhere? As I mentioned earlier, is there some kind of peptic ulcer, bleeding stomach issue, like a cancer or something? You just need to consider other causes. I'd tell him that he's low on that, and that can lead to his symptoms like the fatigue and as well, so it can contribute at the same time. So replenishing that with a good iron-rich diet is the first line. Sort of red meats, talking through giving him some handouts again, say from Nutrition Australia, regarding sort of iron-rich foods, and then also supplements. And if necessary, if he's not really getting any response, and we've ruled out other serious causes in about 3 months, we recheck the iron, maybe discussing parenteral iron infusions if appropriate.
And if there was some ambiguity as to which of the two, being thyroid or iron deficiency, was contributing the most to his fatigue symptoms, what would be your approach in managing that situation?
Sorry, do you mind repeating the question, please?
Yep. If there was ambiguity between the cause of his symptoms being either hypothyroidism or iron deficiency, what would be your approach to managing that situation?
Okay. If there was ambiguity, okay. I guess I would first of all explain to the patient my ambiguity and uncertainty, just in an open, sort of transparent manner, and just get the patient's thoughts as well and see what they think. Secondly, I think I'd probably want to discuss then, if I was uncertain which one was the cause, with an endocrinologist. So I think having a chat to an endocrine registrar, maybe from the local hospital or a private endocrinologist that I know, and just obviously with the patient's consent, running the case by a specialist and getting their opinion. I think in this case, I feel it probably is more the hypothyroidism, but I'd certainly run it by a specialist. I could also discuss with senior sort of GP colleagues as well, see what they think. And then, yeah, even just looking up guidelines, I guess, on hypothyroidism and iron deficiency on HAGP, having a read through ETG, looking at these other reputable sources. I think that's probably where I would start, I believe.
And in terms of follow up and referrals, when do you think dentists should consider follow up, and what kind of symptoms would warrant urgent referral?
Yeah, follow-up and referrals. Okay, sure. So I think with follow-up, it would be so normally I think follow-up, it might not be a bad idea just to see him in about I think about a week week or so after starting on just the levothyroxine, just to see, after you've had that discussion with the patient about starting the medication, just to see how he's going, if he's compliant, if he's had any issues with it. I note here, he's not really a cardiac patient, so he should be fine with sort of a higher dose, I'd imagine. But yeah, just checking with side effects. Has he experienced any palpitations, heat intolerance, sweats, or anything like that? Yeah, just checking that. And so probably in about a week or two. But I think overall, follow-up should be every sort of 4 to 6 weeks. If you add in the levothyroxine, you would recheck the TSH in about 4 to 6 weeks, and just yeah, you wouldn't alter it any earlier than that normally. So even if you increase, and generally you increase the dose by about 25 micrograms, I believe 25 to 50, but generally 25 micrograms. And yeah, so that would be follow-up. And then urgent, sorry, the second part of the question was when to refer him if he had any symptoms. Sorry, urgent referral, did
Yeah.
you
So,
say? Or
what symptoms would warrant an urgent referral?
symptoms for urgent referral. Okay. Um, yeah, sure. So I guess it's a good question. Hypothyroidism. So with overt hypothyroidism, what symptoms would warrant an urgent referral? Yeah, I guess if he's significantly, let me just think. Yeah, I mean, if he's significantly experiencing sort of a lot of fatigue, worsening weight gain, like significant cold intolerance, like his body temperature is dropping, he's feeling getting chill shakes, things like that. I think, if he's dropping below 35, his weight is increasing significantly. And I think if his fatigue is getting a lot worse, then it's affecting his mood and causing sort of depressive type symptoms, and really affecting his energy levels. I think that is probably when you would consider referral. So the question is urgent referral for symptoms of overt hypothyroidism. Yeah, I think that's probably when you'd refer. Yeah, not 100% sure on that, but that's what I think. Yeah.
Yep. Now I'm going to go back a little bit. You have already mostly answered this question, but how would you explain the diagnosis of hypothyroidism to Dennis?
Yeah, so I would tell him that there's a gland in the neck called the thyroid. It produces a particular hormone called thyroxine. And essentially what's happening is he's likely got a condition and underlying sort of, so his own body is generated sort of what we call antibodies, little molecules to attack that thyroid. Because the anti-TPO was positive, yeah. So generated molecules to attack his thyroid, and as a result, this thyroid gland can't produce the normal hormone that it would produce, called thyroxine, and so that's why it's low. That what we call the T4, the thyroxine. So that hormone is responsible for maintaining his metabolism. So making sure his heart rate is functioning, giving him energy, giving him good clear cognition, making sure his digestion system is working, keeping his weight stable. Essentially, I would explain to him the concept of homeostasis in a patient-friendly manner. So essentially, telling him that the body has a balance, and when this hormone is reduced, it kind of throws the body off balance, and that's why he's getting all the dry skin and the hair loss. So sometimes even constipation. So explaining that these symptoms kind of appear when the body goes out of balance. So when this particular hormone, the thyroxine, drops, and that's because his own body is generating sort of a inappropriate response to attack this gland in his neck, and as a result of that, he can't go ahead with causing, allowing normal sort of functioning of the body, is what I would say.
Now you still have a minute left on the clock. Did you want to add any additional information to any of the questions?
Yeah, sure. It's just for the iron studies again. I would just clarify that, as part of the urgent symptoms you mentioned, so I'd make sure there's no other rectal bleeding, alarm symptoms, dysphagia, dynaphagia, melena, hematemesis. I just clarify that because if he does have any symptoms like that, and his iron continues dropping, his hemoglobin could drop as well in turn. So just counseling on that as urgent symptoms to present to the hospital as well. So I'd just like to add that in. And sorry, do you mind just repeating that other fourth question, please? The last question.
Yes. So, when should Dennis consider follow up, and what symptoms would warrant an urgent referral?
Yeah. Okay. And look, if you notice like a swelling in his neck as well, so if he's getting a massive swelling, and that's compressing his sort of windpipe and is causing difficulty breathing, as far as I'm aware, cancers are probably unlikely in hypothyroidism. But if he's noticing any major swelling in his neck, any changes to his
And
weight,
that
things like
is
that.
time. Well done. Getting gold stars across the screen. Well done. And again, thank you very much once again for actually joining in and
Yeah.
running that today. How do you feel?
Uh, Look, it's a case I've done before, and I've had patients with, hypothyroidism. I have started them on levothyroxine as well. I got a bit thrown off by that urgent referrals symptoms. I hadn't come across that for hypothyroidism. I guess I know more of that, sort of like a
Yeah.
toxicosis. But for this, I just wasn't 100% sure on that
No, no,
one.
I think you actually did really well in that section because it was picking up, yes, what are the side effects of the levothyroxine starting medication as well? What are the hypothyroid symptoms that, could be sinister signs of actually other things? So as you mentioned, focusing back on the iron deficiency being a part of it. Could this also be related to that iron deficiency? Why is that happening? And exploring that as well. I think that was really well done. If I go to the focus of what this one was about, right. So a big part of this was correctly identifying hypothyroidism as the primary diagnosis, and then noticing, hey, the iron wasn't up to scratch as well. Could that be a part of it? And just knowing what the guidelines are to manage each of those accordingly. Your communication skills, again, fantastic. I like your communication style. I like the way as well you did adapt the language you used and the pace at which you delivered information when speaking to another clinician. So I thought that was very well done. And when asked about the information transfer kind of thing, you were quite good at focusing in on, well, this is your symptoms, this is what you're feeling, this is why. So again, a good reflection that you take into account the patient's presentation specific to the case, noting it back to, well, what's the question we're asking you? You obviously know the evidence-based practice for managing hypothyroidism. One thing you always can consider, and one of the questions was about if there is that ambiguity, what can you do? And we have the advantage of doing the therapeutic trial of, initiating treatment, getting that review done in that, 4 to 6 week kind of window and saying, is this working? Is this not? And if it's not, we need to say, okay, well, we need to expand our net of what we're looking into. So that was kind of what that was trying to tease out. And again, that's acknowledging the inherent uncertainty that is general practice. But again, I think you absolutely smashed it. That would have been, as far as I'm concerned, a clear pass. Very well done. Take tomorrow off.
Yeah.
Rest up. If you want to practice with a computer, just kind of set it up again. Just make sure everything's working and that kind of thing. But I think you're going to be absolutely fine. For are you Saturday or Sunday?
Sunday. Okay.
Sunday. Ah, excellent. Take Saturday off as well.
Yeah.
Any questions at all? Or
No, that was great. Thank you so much. Your sessions have been absolutely fantastic. So
happy to help, mate.
thank you so much. Yeah, thank you very much for
Cool.
that.
I'll leave you to it.
Hopefully
Feel free to post on any of the videos afterwards how you feel you went on the day, but no concerns from this end, mate. You'll be fine.
Yeah, no worries. Thanks, Kane. Thank you
No
very
worries.
much. Cheers. Thank you.